Good morning. My name is Alexandra Lansky from Yale University. It's my pleasure to be here this morning with Dr. Brian Ference from Wayne State University. We're going to be discussing your late-breaking trial today, long-term reduction in LDL cholesterol beginning early in life. So Dr. Ference, can you give us a little bit of a background on your study?
Right. So as you know, multiple randomized trials have demonstrated that reducing LDL cholesterol beginning later in life substantially reduces the risk of major coronary events. But persons being treated with a statin still experience a substantial residual risk of events. And because coronary disease is a chronic progressive disease that begins early in life and develops slowly over several decades' time before becoming clinically manifest, we aim to test the hypothesis that lowering LDL cholesterol beginning much earlier in life, before the development of atherosclerosis, may prevent, or at least substantially delay the progression of coronary atherosclerosis, and thereby substantially improve the clinical benefit of therapies that lower LDL. Now, ideally, this would be tested in a randomized controlled trial, but unfortunately the cost and the logistical complexity of following a very large number of young asymptomatic people forward for many years' time is likely prohibitive. So as an alternative to a randomized trial, we relied on the principle of Mendelian randomization in order to conduct a series of natural randomized trials to address the question.
So can you give us a little bit of the key points from the results or the findings of
Well,
the
perhaps
study?
it would be wise to first explain the design, if I may.
Okay, absolutely.
So I think multiple polymorphism are known to be associated with slight decreases in LDL. And each of these polymorphisms are allocated randomly at the time of conception in a process sometimes referred to as Mendelian randomization. So inheriting an allele associated with lower LDL cholesterol is analogous to being randomly allocated to a treatment that lowers LDL at birth, while being randomly allocated to while inheriting the other allele is analogous to being randomly allocated to usual care. So comparing the risk of coronary disease among persons with and without such a polymorphism should be analogous to a randomized trial of a therapy that lowers LDL beginning early in life as compared to usual care. So relying on that principle, we evaluated 9 different polymorphisms and 6 different genes. And what we found is that prolonged exposure to lower LDL cholesterol beginning early in life is associated with a 3-fold greater clinical benefit for each unit lower LDL than treatment with a statin started later in life. And that effect appeared to be, it was repeatedly replicated for all 9 SNPs, and the increased clinical benefit of lowering LDL beginning early in life appeared to be independent of the mechanism by which LDL is lowered. And we think that's important because it suggests that diet and exercise are probably as effective as statins or other pharmacologic interventions, at least if begun early in life and when measured per unit lower LDL cholesterol.
So this potentially is a whole paradigm shift in terms of risk reduction and prevention and targeting a much younger patient population. So what are the implications?
I think the implications are several. We think that the study demonstrates that the clinical benefit of lowering LDL depends on both the timing and the magnitude of LDL reduction. And in addition, it appears clear that prolonged exposure to lower LDL beginning early in life before the development of atherosclerosis is substantially more effective at reducing the risk of coronary events than the current practice of beginning to lower LDL much later in life after sclerosis is already developed. And that would suggest 2 things. First, it would suggest that the clinical benefit of therapies that lower LDL can be substantially improved by starting those therapies much earlier in life before the development of atherosclerosis. And it also suggests that a public health policy that focuses on prolonged, sustained reductions in LDL beginning early in life has the potential to substantially reduce the global burden of atherosclerosis.
So when you say early in life, what age group are you talking about? We're talking about the pediatric patient population?
No, not necessarily.
Here,
no, because although each of the polymorphism was associated with a lower LDL cholesterol, presumably that begins at birth, the hypothesis that we aimed to test was whether or not lowering LDL before the development of atherosclerosis is more effective than waiting until after atherosclerosis develops. And because we're born with LDL somewhere between 50 and 70 milligrams per deciliter, and that level begins to rise late in the teens and early 20s, that's about coincident with the time that atherosclerosis begins to develop. So I wouldn't contemplate treating children with medicines to lower LDL. But having said that, it would be wise as a public health policy to promote diet and exercise as throughout the whole of one's lifetime, with the aim of keeping LDL as low as possible. And then perhaps persons in their 20s who can't maintain an ideal LDL level, whatever that level may happen to be, and the study didn't address that, then at that time we could contemplate adding something like a statin or some other pharmacologic agent to maintain very low levels of LDL throughout the whole of one's lifetime.
And is there any recommendation in your study or any findings in terms of the testing the LDL levels at a younger age?
No, I mean, the American Society of Pediatrics now recommends earlier intervention, earlier screening and awareness of LDL levels, and we think that's wise, simply to identify those persons that have very high levels of LDL beginning early in life, but also to help focus people on the awareness of the dramatic benefit of keeping LDL lower beginning early in life before the development of atherosclerosis.
Well, thank you very much. Fascinating trial, I think very important from a public health perspective. I want to thank Dr. Ference and thank you very much for this interview.